Hello, everyone. My name is Maria Lombardi, and I'm here to present my capstone project, the final requirement for the Masters in Healthcare Interpreting program at the Rochester Institute of Technology, National Technical Institute for the Deaf. My topic focused on interpreting for deaf children in the healthcare setting. Sign language interpreters work in a variety of settings, including legal, medical, educational, and mental health. This study specifically focuses on the medical setting. There are specialized certifications, qualifications, and trainings available for those who choose to work in these settings. There is not a nationwide consensus of what constitutes a qualification to work in these settings, according to Sean Walker's article 2011. Most available certifications and trainings assume that the end user of the services are adults, according to Dahl and Wilcox's article 1990. Even if an interpreter is qualified to work in these settings, the qualification does not traditionally account for working with children. Children often present unique challenges when interpreting. For example, children have limited vocabulary knowledge. The interpreters have to assess the comprehension levels and behavioral issues, to name a few, according to Schick and Spencer's article 2013. Little research exists on interpreters who work with children in the medical field. The current research focuses on working in medical settings with adults. This study investigates the strategies acquired by interpreters on the job, specifically those who work in medical settings and those who work in educational settings. The study addresses the question of which setting affords interpreters the most effective on-the-job experience of working with children, experience which then can be applied to working with children in the medical settings. Current literature can be expressed and broken down into 5 different categories: interpreting as a profession, interpreting for children, educational interpreting, medical interpreting, and demand control schema. In the field of sign language interpreting, there is not only an evolution of the profession, but also an emergence of specialized settings. The Registry of Interpreters for the Deaf have produced standard practice papers, also known as SPPs, over various topics including K-12, legal, mental health, healthcare, religion, and many others over the last 20 years, addressing the standard practices and skills needed to become successful in those specialized settings, according to RID.org. RID.org states that ASL interpreters first became recognized as professionals in the late 1960s with the establishment of RID in 1964. Since 1964, RID, in conjunction with the National Association of the Deaf, has created a national standard of conduct for sign language interpreters, providing equal opportunities for all members and educating the public on the importance of using an interpreter. In 1990, the Americans with Disabilities Act and the Rehabilitation Act of 1973 mandated that deaf individuals are provided with reasonable and equal access to communication, according to ADA.gov. As the interpreting profession grows, the need for interpreters with a specialized skill set is in high demand, according to Witter-Merrithew and Nicodemus's article 2010. Interpreting for children is a largely unexplored field within the profession of interpreting, according to Nielsen's article 2021, which specifically focused on the healthcare field. Children begin receiving exposure to language from the time they are born, both visually and auditorily. With repeated exposure to good language models, children start to acquire language. Children, both hearing and deaf alike, learn to watch their parental figures, gesturing to objects, babbling, and by the age of 2 are developing word or sign acquisition, according to Seal's book in 2004. According to Meyer's article of 2016, children can successfully acquire language during what is referred to as the critical period. This is before the age of 5. Children hit various milestones and work towards new sets of milestones as language is acquired. The lack of language accessibility is known as language deprivation. Early exposure to language reduces the risk of language development and deprivation in children. The most common placement of deaf children is in an inclusive environment with their hearing peers in the mainstream setting. Children within the inclusive setting typically obtain less content knowledge than their hearing peers, even with sign language interpreters, according to Marchek et al. 2004. Deaf students generally enter school with less developed academic knowledge and cognitive differences than those of their peers. Upon the emergence of specialized settings within the field of interpreting, educational interpreting proved to provide advancements in the field of interpreting. In 1975, the creation of PL 94-142 required all handicapped children to receive an education. Later, the establishment of IDEA and the ADA created a need for qualified interpreters or the use of other appropriate accommodations that would provide equal communication access according to RID's Standard Practice Paper 2010. Individualized educational plans, also known as IEPs, were created in response to some of these challenges faced. IEPs are used to determine the individual educational needs of the children in the educational setting. Due to the majority of deaf children placed in inclusive educational environments, sign language interpreters are critical to provide accessible education. Educational interpreters must possess the ability to accommodate the individual needs of the children whom they interpret for. According to Seal's book, Best Practices in Educational Interpreting of 2004, many researchers argue that anyone who communicates to a child during the early learning stages is recognized as a language model or language teacher. Therefore, an educational interpreter is seen as interacting meaningfully with a child, integrating new information into one's existing knowledge. Seal 2004. Research shows that interpreting for children requires a unique set of skills that allows for successful communication. Sign communication use, sign selection, performance criteria, pacing, and background knowledge of the interpreter all play a role in the production of one's interpretation. Stewart and Quinn, 1996. Effective communication between deaf individuals and hearing providers within the medical setting is critical for successful health outcomes. Section 504 of the Rehabilitation Act prohibits discrimination against individuals with disabilities, denying them goods and services according to RID's Standard Practice Paper of 2007. Sign language interpreting is necessary to provide access to information like patients' medical history, treatment plans, medical education, and hospital procedures according to the practice paper of 2007. Research shows that deaf and hard of hearing individuals, compared to that of the hearing population, tend to have fewer doctor's visits, participate in fewer preventative services, and often experience more misunderstandings regarding medications and follow-up procedures, according to Shear's article 2009. Consistent evidence showed limited understanding of diagnosis, provider instructions, and medication risk by deaf individuals, according to Holmes et al. Study of 2018. While this is true, interpreters hardly observe the use of teachback to ensure understanding of the appointment. Lack of anatomical models and pictures, lack of empowerment or the ability to ask questions, and time constraints provided challenges within the setting. Often healthcare providers rush through appointments, therefore communication is lacking, according to Holmes et al.'s article 2018. Dean and Pollard's demand control schema of 2013 focuses on interpreting as a complex process that requires a complete understanding of the communication situation, the goal of the environment, and the goals of those involved in the communication. Demand control schema, also referred to as DCS, teaches interpreters how to understand the goals of the environment and the goals of the individuals. This allows the interpreter to make better decisions regarding a variety of presented situations. Dean and Pollard's schema focuses on a two-part schema. The first part discussed in Dean and Pollard's book is demands. Demands are what are referred to as salient aspects of our work, the factors that rise to a level of significance that will impact the decision-making involved in one's work. Dean and Pollard 2013, which was found on page 4. The interpreting demands include environmental, interpersonal, paralinguistic, and intrapersonal, better known as EIPI. The second part of the schema focuses on controls. Controls refer to how interpreters interact and respond to the presented demands of an assignment. Controls are resources the interpreter has at her or his disposal, or a response the interpreter offers in light of assignment demands. Dean and Pollard 2013, which was found on page 15. For this study, participants included 6 certified sign language interpreters, 3 educational, and 3 medical. All participants were recruited via personal contacts and snowball sampling. Participants included 5 females and 1 male from 4 states across the United States. All participants in this study were volunteers. To qualify for the study, participants had to satisfy specific criteria, including holding current certification through RID or BEI, holding other specialized training in either educational or medical interpreting. They must have worked in either an educational or medical interpreter for the last 10 years. They must have no experience in the opposing field or less than 1 year experience was preferred. Informed consent forms were given to participants containing information about eligibility requirements, procedures, benefits, and risk of participation in the study. Voluntary participation and contact information for myself, the researcher, was also given. Additionally, participants were given an 8-question demographic survey. Participants were asked to indicate their education level, certifications obtained, years of experience, which field of interpreting they worked in, and if they had familiarity with DCS. Participants were asked to fill out the demographic survey and informed consent form and return it via email to myself. Upon receiving these forms, a time and date was scheduled to have the interviews participants in order to have the interview. Participants were not contacted until the project was approved by the review board. The research design of the study was qualitative in nature as a means of assessing medical and educational interpreters' practical knowledge of working with children. For the purpose of this study, 6 interviews were conducted and recorded via Zoom. 4 fictitious scenarios were created by myself, the researcher, all encompassing a deaf child in a medical setting. Participants were asked to review each scenario and state any demands they felt were present in each scenario and any controls the interpreter would use to mitigate those demands. Scenarios encompassed a variety of medical settings, including the emergency room, speech pathologist clinic, a local clinic, and physician's office. Age range of the children in the scenarios were between 6 and 14 years of age. Upon completion of the 4 scenarios, 2 follow-up questions were asked of participants. Participants were thanked for their participation and asked if they had any question about the study. Participants' interviews were conducted and recorded via Zoom. Each interview was transcribed and analyzed via an Excel spreadsheet. Transcriptions were then analyzed looking for similarities and differences between the 2 groups of participants that were interviewed. The Excel document was set up including headings that stated participant numbers, line numbers, quotes from the participants, educational or medical interpreters, the category specifically demands or controls, subcategory of the demands and controls, and lastly the scenario numbers. The data was analyzed in 3 different ways. First, data was categorized by demands and controls. Demands were broken down into EI/PI categories, and controls were all grouped together. The next breakdown of the data involved breaking down the demands and controls into subcategories. Lastly, the data was separated into scenarios 1 through 4. The data was grouped initially by demands and controls for each scenario, then from there broken down into medical and educational demands and controls for each respective scenario. The chart represents how many control options were given overall for all 4 scenarios and the breakdown of the EI/PI demands for all the scenarios. Environmental and interpersonal demands were the most prominent of the demand categories listed overall. An example of each EI/PI demand was given based on the responses for the scenarios. Participant 4 stated a paralinguistic demand, which was how developed their languages at this age could be a demand for both sign language and spoken language. Participant 6 stated an interpersonal demand, typically, providers will do and say at the same time. For example, it's time to look in your ears while simultaneously walking up to them to look in their ears. An environmental demand was stated by participant 6. It is usually the placement of the doctor during the exam, which is challenging to have a line of sight. Lastly, an intrapersonal demand was identified by participant 3. I am feeling sorry for the deaf female. Life isn't fair sometimes. Interestingly enough, few paralinguistic demands and even fewer intrapersonal demands were given for all scenarios. Control option examples were also given in response to the initial breakdown of data. Participant 2 stated that they would be reminding people in the room that communication is not successfully happening. Participant 4's control was based on their experience in similar situations. They stated before going to interpret something, the interpreter would want to bring it back to their goal, asking the provider if they would like me to interpret it this way. Participant 6 stated a control in this setting is to ask the child to do a teach-back after the staff has already explained the importance of allergies, making sure the child understands. Lastly, participant 5 stated that they would ask the child to repeat himself, thus mirroring what the child signs back to the child to see if they can correct me. It might help me understand better. From an analysis perspective, control options varied from each participant. Overlaps were noted when the participants had the same background. The data was then broken down into subcategories as shown in the graphic. Data showed that the medical interpreters identified fewer demands but had a wide range of control options. The opposite was true for educational interpreters. The educational interpreters identified a variety of demands, but their control options were narrow. The number of demand and control categories is shown in the graph. From a standpoint of analysis, the medical interpreters ask a lot of questions about the scenarios, resulting in a multitude of control options, whereas the opposite can be seen from the educational interpreters who did not ask questions. The medical control group identified 19 control category options compared to the 12 the educational interpreters identified. Demand categories identified by educational and medical interpreters were placed next to each other and compared. Several similarities were identified between the groups as well as some differences. The differences included a category of thoughts, feelings for the medical interpreters. Educational interpreters identified additional categories of turn-taking, cultural differences, and pace. For analysis purposes, several demand categories were identified between both groups equally. Notable similarities were that of vocabulary, communication flow, and the use of an interpreter. Control categories identified by educational and medical interpreters were placed next to each other and compared. Several similarities and differences were identified between the groups. Medical interpreters identified several additional control categories compared to that of the educational interpreters. Medical interpreters identified teachbacks, decline of an assignment, comfort, pleasant demeanor, building trust, rescheduling an assignment, request, and communication flow. The educational interpreters only identified one additional control option of studying the content. The additional categories identified by the groups are representative of the work environments the interpreters work in. Often, educational interpreters are studying content that is being discussed in the classroom before interpreting it. Medical interpreters identified several controls that are often used in the medical setting, such as comforting the patient and using teachbacks to ensure communication comprehension. The next few slides go over a few quotes from some of the demand and control categories identified by the participants. In the demand categories, the goal of the environment was identified, specifically identifying the goals of speech therapy. Participant 4 stated, quote, I would be curious about the students' goals for speech, whether it was articulation goals or language goals for speech, whether the language, specifically sign language, would be suitable or if they were focusing on spoken language goals. This was stated by participant 4, who was an educational interpreter. In the domain categories, physical limitations were identified. Educational and medical interpreters equally identified language disfluency due to CP as a demand. Participant 2 stated a demand is that there is a spectrum of how much the disability affects the child's ability to communicate, both signing and speech. This was given by participant 2, who was a medical interpreter. In the demand categories, utilizing an interpreter was identified. One educational and one medical interpreter recognized the demand of the child not having any experience of working with an interpreter. Participant 5 stated, "Does the child normally work with an interpreter?" This appointment could be the child's first experience. Participant 5 stated this quote, and they were an educational interpreter. In the demand categories, attention was identified. Medical interpreters identified the demand being keeping and maintaining the child's attention, whereas educational interpreters focused on the child not attending to the interpreter, but other things in the room or his or her pain. Participant 6 stated due to the fact that attending to one's eyes is very different from attending with one's ears. If you can hear, the child is 6 years old and doesn't have a long attention span for an interpreter. Participant 6 stated this quote, and they were a medical interpreter. Now switching to the control categories, teachback was identified as a control category. One medical interpreter identified this as a control option, and no educational interpreters identified this as a possible control. Participant 6 stated, quote, "A control in this setting is to ask the child to do a teachback after the staff has already explained the importance of allergies, allergic reactions, EpiPens, etc. Making sure the child understands what caused it and how it is treated so the staff could give a yay or nay and add more teaching if necessary." Participant 6 here was a medical interpreter. In the control categories, interruption was identified. Medical and educational interpreters equally identified deferring to the medical professional and asking for clarifications or examples for various topics in all the scenarios. Participant 4 stated, quote, "At this point, I could see myself as a control interjecting and seeing if the doctor can offer any examples of symptom descriptors of what the child might be experiencing to kind of pull out some of that because the girl doesn't seem to understand the question." Participant 4 was an educational interpreter here. In the control categories, placement was identified. 2 out of 3 educational and medical interpreters identified making sure the interpreter was within the child's vision, positioning themselves based on the environment as a control option. Participant 6 stated, quote, "It is a matter of positioning myself based on the orientation of the therapist and the child. That would be a control option to make sure I can easily be seen by the child." Participant 6 stated this quote, and they are a medical interpreter. In the control categories, resource was identified. Both medical and educational interpreters equally identified the controls of contacting the previous interpreter and consulting with the father and the therapist prior to the appointment for guidance. One medical and one educational interpreter wanted to inquire about specific goals for the assignment as a control. Participant 4 stated, quote, "I would have an opportunity then to ask about the specific goals for not only the therapy session, but also the goals for the student." Participant 4 stated this, and they were an educational interpreter. The data was separated into scenarios 1 through 4. The data was grouped initially by demands and controls for each scenario identified by the orange and green colors on the graph. Then from there broken down into medical and educational demands and controls for each scenario, which are represented by the other 4 colors on the graph. In scenario 1, controls and demands were almost equal in numbers. Interpreters identified more control options than demands in scenarios 2, 3, and 4. Overall, when looking at the graph, we can see that there is a decrease of controls and demands identified in each scenario. It can be speculated that this is a possible decline due to people initially being motivated to answer and less motivated as each scenario was discussed. Interesting characteristics from the given demands for each scenario were analyzed and broken down here. In scenario 1, 2 out of 3 educational interpreters identified the demand of the goal of the therapy appointment, specifically focusing on if the goal was language or articulation oriented. 1 out of 3 medical interpreters identified the goal of the appointment as a demand. All but one medical interpreter identified language disfluency as a demand. Educational interpreters identified demand of the therapist not knowing how to work with an interpreter, but medical interpreters identified the child might not know how to work with an interpreter. In scenario 2, sightline and attention of the child was given as a common theme between all educational interpreters and medical interpreters. Medical interpreters identified the demand of the child being resistant to the examination. 2 out of 3 medical interpreters identified the demand of the doctor talking and doing the exam simultaneously compared to one educational interpreter. From the standpoint of analysis, medical and educational interpreters in these two scenarios identified some similar demands. The educational interpreters were more focused on the goals of the appointment and the interaction between participants, whereas the medical interpreters were more focused on the language of the child and if the child was able to work with an interpreter, specifically if they were being resistant to the interpretation process or if they knew how to utilize an interpreter in general. In scenario 3, 2 out of 3 educational interpreters identified vocabulary challenges, whereas no medical interpreters identified it as a demand. Educational and medical interpreters equally stated the child not making eye contact and was uncomfortable. One educational and one medical interpreter stated the girl not understanding the question was a demand. In scenario 4, limited demands were given in by both groups. One educational and one medical interpreter identified anaphylactic shock and allergies as not being defined as a demand. Lastly, sloppy signing, struggling to talk was identified equally between both groups of interpreters. From an analysis perspective, educational interpreters focused more on vocabulary, comprehension, and the sloppy signing as presented demands compared to medical interpreters who focused on the lack of eye contact and the incoherent signing. Interesting characteristics from the controls identified across all 4 scenarios were identified and broke down. Scenario 1 controls presented that one educational interpreter wanted to use consecutive interpreting because of the challenges that come with CP. All interpreters, both educational and medical, wanted to contact the previous interpreter and consult with the therapist, the father, and the child all prior to the appointment. One educational interpreter wanted to interject during the appointment and ask for clarification. And lastly, one medical interpreter had the control of filling in cultural gaps. Scenario 2 controls presented that educational interpreters identified they would condense the information and relay the goal of the questions, where only 2 medical interpreters identified this as a control. 2 out of 3 medical interpreters identified building trust with the child as a control. Lastly, all educational interpreters mentioned waiting for eye contact before beginning their interpretation. One medical interpreter stated they would get on eye level with the child. From an analysis perspective, educational interpreters would use their resources, previous interpreter, parents, the therapist, etc., in order to find out background information, as well as condensing the information presented in order to make sure the goals were clear and information was relayed. Medical interpreters would make sure they built trust and had rapport with the children and used their resources by contacting the previous interpreters. Scenario 3 controls identified were both medical and educational interpreters equally identified a control as expanding on the questions or terms used within the appointment. 3 medical interpreters and 1 educational interpreter identified waiting for eye contact as a control. The educational interpreter even explained why eye contact is essential in ASL. 1 medical interpreter identified a control of voicing sounds for facial expressions given, even if no words were spoken or signed. Scenario 4 controls identified were that all medical and educational interpreters stated they would use the control of informing the professionals of the lack of clarity with the child's language, interpreting what was seen. 2 out of 3 educational interpreters asked for clarification from the provider. 1 medical interpreter asked the mother of the child for clarification, and another used the teach-back method with the child to ensure comprehension. Lastly, 1 medical interpreter stated they would use more high context interpreting in order to explain a concept. From an analysis perspective, educational interpreters identified that they would expand on the questions or terms within the appointments and that they would inform the medical professionals of the disfluent language being observed and ask the medical professionals for clarification. Medical interpreters, on the other hand, stated they would expand on questions themselves, wait for eye contact, and use high context interpreting. Upon completion of the 4 scenarios, 2 follow-up questions were asked, inquiring about the skills needed to interpret for children, and any helpful tools the interpreters had used in their line of work. The responses were reported, a few similarities were noted, including thinking outside the box when working with children, because, as multiple interpreters stated, no child is the same. Another similarity was employing the use of a team, or CDI if one was available. Medical interpreters felt it was important to connect with the children and make sure the goals of the environment were successful. Educational interpreters felt it was important to check back in with the child and ask questions to ensure understanding and be able to adjust their interpretation, matching the child's language level. The presented data can be interpreted in several ways. One way to interpret the initial data of the medical interpreters stating more controls than the educational interpreters is because medical interpreters are in an environment where the patients and scenarios that are seen are constantly different. This would explain why the medical interpreters ask a lot of questions during the interview, thus resulting in a multitude of control options. Vice versa, educational interpreters have a consistent environment in the classroom and have a handful of controls that they use in order to mitigate the demands that come up in the classroom environment. It can also be inferred by the data that the medical interpreters do not see many challenges or demands presented in these medical scenarios because these interpreters are used to these kind of situations. But the treatment options are often different, therefore medical interpreters are used to having multiple outcomes, hence the increased number of controls given. The educational interpreters viewed these situations challenging because they are not used to the environment but rather used to working with children. The demands given by the educational interpreters were focused on linguistic elements and interactions involving the child rather than the environmental aspect. Looking back at the literature, Schick and Spencer 2013 stated that unique challenges are presented involving children, including limited vocabulary, behavioral issues, and comprehension. This is relevant for my data as several demands were stated by both groups of interpreters, involving challenging vocabulary, retention, and comprehension of certain topics, according to Marchek et al.'s article 2004, which stated children in inclusive settings obtain less content knowledge than their peers, even with sign language interpreters. This point was interesting to look back on with my data. Some educational interpreters wanted their controls to be making sure the child was informed of everything going on in the room, so they had informed consent and were also learning new things. Compared to the medical interpreters, who did not mention this as a control, their focus was on the goal of the appointment rather than informing the child of these sorts of things. Nielsen's article 2021 stated that the interpreters in general must juggle a child's language, specific vocabulary, and be able to expand on concepts. This is true for sign language interpreters who are working with children. My data proved that vocabulary challenges and expansion of concept were one of the biggest demands encompassed in each scenario. Lastly, in Seale's book of 2004, it was stated that interpreters are language models. They engage children during new interactions and fingerspell new words. A few of the controls given were to expand or fingerspell new concepts and make sure there was an understanding. Medical interpreters chose to expand on the concept mostly themselves, while the educational interpreters chose to defer to the medical professionals. Continuing to look at the literature, Holmes et al. 2018 stated that providers often rush their appointments, don't use teach-back methods, and lack in the use of pictures or the use of anatomical models. The medical interpreters tended to identify the demands and base their controls off of these characteristics that describe the providers. It can be inferred that because medical interpreters are used to working in these environments, they are able to identify these demands and come up with possible controls to combat those demands. Dean and Pollard's 2013 demand control schema identifies 4 EIPI demands or salient aspects of one's work and the responses of those demands known as controls. The demands and controls identified were each different based on the interpreter. This is consistent with my data as well as with Dean and Pollard's schema. Lastly, Dean and Pollard stated that control options are considered to be different based on one's background, knowledge, personalities, and experiences with assignments. This is presented in my data with the variances and controls from the medical interpreters and the educational interpreters. In summation, educational and medical interpreters each obtain their own set of skills acquired to work with children in the medical environment. Some similarities are seen across both groups of interpreters, as well as a wide variety of differences. Educational interpreters felt out of place and uncomfortable with the setting involved in all of the scenarios during the interview process. Medical interpreters were more comfortable because of the medical scenarios. If the medical interpreters were given scenarios involving children and educational interpreters were given educational scenarios involving children, the data could have proposed different sets of demands and controls. The interesting result of the demand control distribution would have been flipped if educational scenarios were given. Medical interpreters would have identified several demands but not known how to mitigate them. I made the choice to present the participants with only medical scenarios, but I would be interested to see the demands and controls if they were presented with both educational and medical scenarios. Because interviews were conducted on Zoom and presented, a lot of the time was spent adjusting to the technology, sharing the screen, and dealing with any other technological difficulties. If these interviews were conducted in person, things would have been different. I also believe that if I had diverse range, a bigger diverse range of participants, specifically more males rather than a heavily female sided participant pool, the research could have been different. This research is relevant as it impacts interpreter trainings, specifically skills needed to work with children. Research shows that skills needed to work with children are different than with adults. Research also shows that there are a variety of skills that can be useful when interpreting for children, depending on the scenario and demands identified. This research could also impact doctors in how they could improve their medical access and interpreting services. Further research is needed on the topic of interpreting for children in medical settings. The research can be branched out in a few different ways. It is interesting to see from my research that medical and educational interpreters identified skills for the next part of this research. It would be interesting to set up a more experimental setup involving mock actual situations where interpreters cycle in and out of a room and interpret the actual thing or assignment that is going on and then reflect on it. This would be interesting to see because in my research, everyone had many questions on things that happened, whether that was if the provider was male or female, if the child had worked with that interpreter before, if the child had been to that hospital before and seen that provider, if the child was used to being with that parent, for example, if they are typically with mom for appointments, but dad was the one to take them and how they responded to those things. So a variety of questions were asked during my interviews that I think that ultimately impacted their answers if they would have had a different answer or maybe a different scenario presented to them. Another approach would be to be providing a training to medical interpreters using the strategies that were found that educational interpreters bring to assignments and then test the medical interpreters before and then after in order to see how many demands and controls they can spot. Lastly, another perspective would be to look at things more from a quantitative measure rather than qualitative and get actual numbers, maybe using more participants, both medical and educational, and having some kind of um, jumping off point as to what is actually considered qualifying to interpret for children. I want to thank you for listening to my presentation. The last four slides are just my references. I will go ahead and click through these here. Again, thank you for listening to my presentation on interpreting for children in the healthcare setting. I appreciate your attentiveness. Thank you.